So this case is a relatively young male, and I think here the gender is important to focus on in this case. So the patient experienced chest pain and came to the emergency unit. ECG revealed ST elevation. History, there is no previous history of risk factors. There is no family history of heart attacks, no diabetes, no hypertension, and a healthy lifestyle. This is the angiogram. And again, we are discussing cases with unobstructed coronary arteries. So the coronary arteries, right coronary, left system, everything was fine in the angiogram. So as a kind of investigating minor, among the investigations, the echo returned back normal. So there was no abnormal wound motion abnormalities. There is no LV dilatation. Function was preserved. Among the investigations, the MRI, those are the long axis. On the right side, or on the right panel, 4-chamber view, and on the left panel, 2-chamber view. Function is good. Valves are intact. No left ventricular dilatation. Short axis view. Again, function is good. The radial function is preserved and there is no dilatation. And among the differential diagnosis was the myocarditis. That's why, or this is the reason why we have done the term or the edema sequences. Could anyone see edema in these images? I'm not sure if the resolution is clear, but mid to apical, we have the anteroseptal edema. Right? So we have edema all through here. Anteroseptal. I'm not sure if are the images clear.
Yeah, the anteroseptal is clear now. Yeah, it is.
So it's a regional edema in one territory, although the catheter was normal, but again the edema was regional. Let's move to mapping, which confirmed what we saw in the turbo inversion or the edema sequences. So the T2 came back 67, which is elevated, and the T1 map 1200, which is elevated or prolonged T1 map, time for 1.5 Tesla, and confirmed what we saw about the edema. Moving to the late enhancement. So we have the 3-chamber view on the left side panel and the long axis on the right side panel. Could you see any enhancement? Let's move to the short axis. Late gadolinium enhancement. Any kind of enhancement, and what type?
Anteroseptal.
Exactly the same location and the same territory where we saw the edema, right? Would you describe this as ischemic type of late gadolinium enhancement or non-ischemic type of late gadolinium enhancement? Because in this case, it is the clue whether this is a ischemic type or non-ischemic type. And as we mentioned, this is a male. And I told you about the history that we received at MRI. And there is a clue or a piece of a clue that I didn't tell you about, because we didn't know it in the MRI until we went in the MDT. And they told us that one day before the presentation, this young male had a dog attack. And one day afterwards, yeah.
Excuse me, had what attack?
Dog attack. So.
Oh, okay. Okay.
So during the MDT, as a matter of fact, at the beginning, we started thinking about the coronary spasm again. But when the clinicians mentioned the dog attack, we started thinking about atypical Takotsubo.
Takotsubo.
Yeah. And the patient, that was the correct diagnosis. So the patient had a Takotsubo. 10 days later, everything has improved and there was no edema and everything has improved. And this was a case of atypical Takotsubo.
But the thing is, if it's atypical because it's in the basal anteroseptal part. But why late gadolinium enhancement in this case was evident and T1 changes?
Well, during Takotsubo, what happened is the edema, right? And the edema itself, either it's extracellular edema or intracellular. And if it's extracellular, this means that there is expanded extracellular space, which would give you a prolonged T1 time in the T1 maps, and will show this faint mid-wall enhancement in the late gadolinium enhancement. The only thing that was against Takotsubo was that it's territorial, it's in the anteroseptal, as if it's following one coronary artery territory. That's why the diagnosis was of atypical Takotsubo, but again, the catheter revealed that there is no coronary artery disease in this case, and this confirmed by the catheter. Yeah, any questions?
Oh, thank you. Thank you, Doctor. Thank you.
Well, I think those are my 3 cases. Thank you very much.
Thank you very much, Doctor.